Lucy was becoming a safety risk at the facility, and the director of the senior apartment living approached the daughter and said, I think we need to put Lucy into a memory care unit across the street, but I have one idea. What do you think about cannabis? And the daughter said, I'll do anything I can to help my mom stay in her apartment and age here and not go into a memory care unit. And why do you think they come to me? I always say, why now? Why are you coming to cannabis now? I want something more natural. My medications aren't working. I'm tired of the side effects. And I'm a big fan of doing one cannabinoid at a time. We know that cannabis has so much to offer. So I make them wait 3 to 5 days before they even increase their dose. Even if it's not working, I want to make sure that we're going that low and that slow.
And I said, I think there's a need out there to help people navigate through cannabis as a medicine. And he said, you're going to be a drug pusher? And I said, isn't that what we do here? And he said, touche. But we do need to market to this community because they vote and they are our best advocates. And if you want to build an army right now, get the seniors on your side. Get them off their pharmaceuticals. They will write to their legislators. They'll be active in their community, and they will help us move this forward.
I do want to start out with a story, one of my favorite, most profound stories. I met Lucy when she was 89 years old, and she'd been diagnosed with advanced stage dementia. For about the last 5 years, she'd been experiencing forgetfulness to the point where she was falling, and it had become a risk, a safety risk. She lived in an independent senior apartment complex. And Lucy wasn't able to form her words anymore. She didn't make sense. She spoke gibberish. 40 years prior to her diagnosis of advanced stage dementia, she'd been diagnosed with multiple sclerosis. And so she had 40 years of chronic pain, headaches, and insomnia that pharmaceuticals didn't touch. Yet they continued to give her more and more pharmaceuticals. So by the time Lucy and I met, she was on many medications. And the average amount of medications for somebody over the age of 65 is about 5. In my practice, I see 7. And advanced stage dementia patients typically are on about 12. Lucy was becoming a safety risk at the facility, and the director of the senior apartment living approached the daughter and said, I think we need to put Lucy into a memory care unit across the street, but I have one idea. What do you think about cannabis? And the daughter said, I'll do anything I can to help my mom stay in her apartment and age here and not go into a memory care unit. So Lucy didn't know what was going on. Her daughter had durable power of healthcare. We put her on a program. I started her on a very low dose of a 1-to-1 THC to CBD, 5 milligrams twice a day, and at night I gave her 10 milligrams. And within 3 months, Lucy was off all of her pharmaceuticals except her high blood pressure medication. And guess what? Lucy got her memory back. She was alert and oriented. Her pain was gone. She was sleeping through the night. She was doing so well that she was no longer being at risk for having to go to this memory care unit. They removed the diagnosis of advanced stage dementia from her medical records. And her daughter decided, I'm going to surprise my mom with a trip to France because that's where Lucy was from. So the daughter called me up and she said, Eloise, how do I travel to France with her cannabis? And I went, you don't, right? And she said, okay, well, what do you think we should do? I said, I think we should wean her off of it and see how she does without the cannabis. She's been on it for now. Oh, okay. And so we did. We weaned Lucy off. And within a week off of her cannabis, her pain came back, and she wasn't sleeping again. And because she had to go on this trip, her daughter decided to put her back on pharmaceuticals, and so they put her on gabapentin, and within a week, she became confused again. And her daughter called me, actually she emailed me, And she said, I can't do this to my mom. I'm just going to go ahead and mail the cannabis ahead of time to the hotel in France. And I went, okay, I didn't hear that. And I said, good luck. I'm really sorry that this is the way it has to be. And a week later, I got an email that the Eagle had landed. All right, so in case you're wondering who that is, that's me. When you get a headshot like that, it's really hard to live up to those expectations. And in the last couple weeks, I had somebody ask me if that was my daughter and if my husband was my son. So they photoshopped that. Yes, I have gray hair. I've had it all along. So what qualifies me to be here? I'm an advanced practice nurse. All of those initials stand for adult, geriatric, primary care nurse practitioner. I'm board certified. Or as my daughter says, alphabet soup. Or as I say, $3,000 an initial. I'll be paying for the rest of my life. So at this point, I've treated over 5,000 patients. And a lot of the things that you've heard already today really kind of tie into this. The average age of my patient is 76, and most of them are female, about 85%. They've never used it before. They're cannabis naive. I hear a lot of people talk about how seniors are the fastest growing demographic of users, but yet they've had a long time relationship with cannabis. Not in my practice. The 76-year-olds typically were working or raising kids, and they really did miss the 60s and summer of love. So they're cannabis naive. And about half of them want to use cannabis for pain. The other half want to use it for sleep. Of course, they always say, I don't want to smoke it, I don't want to get high, and I don't want to get the munchies or gain weight. So I want to talk a little bit about the clinical implications around cannabis. And again, this segues, ties in nice to the last speaker. I see a lot of patients who are coming to me for sleep insomnia, and this is just a quick snapshot of 94 patients. So about 20% of men were coming to me for sleep. And there's some very interesting details or differences between men and women. Men have a harder time falling asleep. Women have a harder time staying asleep. And there's a lot of contributing factors with sleep that I notice. Alcohol. I never knew how much older people like to drink until I got into cannabis. And I mean, I'm not kidding. So I usually ask them if they'd like to reduce their alcohol intake with cannabis as well. But as we age, of course, starting to go through menopause, a lot of that can lead to issues with sleep. And these are the common pharmaceuticals that I see in my practice when they come to me, and these are the ones that I get them off of. And why do you think they come to me? I always say when they come into my office, I say, why now? Why are you coming to cannabis now? I want something more natural. My medications aren't working. I'm tired of the side effects. And cannabis can be a very safe and effective sleep aid, much safer than many of our pharmaceuticals, both over-the-counter and prescribed. And I also find that very small amounts of THC work beautifully because CBD can be stimulating. And it's in about a third of the women that I see, they're going to have a stimulatory effect. So what happens? They walk into a dispensary. They say, I don't want to smoke it, I don't want to get high, and I need help sleeping. And they're offered a CBD product, which actually can keep them up all night. And then they think cannabis doesn't work for them, and they give up. And if they're having a hard time falling asleep, I do try to encourage inhalation. I find that after, educating patients about the risks and benefits of inhalation, I can get about 60% of them to actually reconsider inhalation as an effective method. And edibles and tinctures can be very effective for helping patients stay asleep. My background prior to coming into cannabis was cancer oncology. So I naturally get a lot of oncology patients who want to use cannabis to manage their symptoms, either related to their disease or their chemotherapy regimen. Another quick snapshot here. So most of them want to come to cannabis for nausea and vomiting, appetite loss, anxiety and depression, pain and sleep. So they can actually have multiple comorbidities going on. And these are some of the common pharmaceuticals that they're on that they want to get off as well. They recently did a survey on oncology patients and asked them how well their nausea was being controlled with pharmaceutical antiepileptics. 75% of them reported it was not being well controlled. And anxiety and depression can be, a lot of times they see this as a comorbidity because they're not sleeping, they're in a lot of pain, maybe they just lost a spouse, they're actually having fears around dying, other health issues. And so they want to use cannabis instead of their benzodiazepines, their antidepressants. And it can be challenging in some cases. Again, women tend to be more sensitive to cannabinoids in my experience, and so they typically need less. Sometimes they can have that biphasic or bidirectional effect, where a low dose can increase anxiety, and a high dose may actually reduce it. And so appetite and weight loss, when people come to me and they say, Eloise, I don't want to get the munchies, and I say, well, you probably won't, because women typically have a harder time stimulating appetite with cannabis. So if they don't want to inhale it, it can be extremely challenging for me to help them get their appetite up, because that's the most effective method in my experience. And we have found that CBD over time can suppress appetite. So if they're at risk for weight loss, we really want to monitor these patients throughout their care to make sure that they're not at risk. And this was already mentioned, but there is a hormone that gets stimulated. I think it was mentioned. You never feel like you live in can't remember what you said to who, when, where, or what. Yeah, it's not the cannabis, I'll tell you that. So when we use cannabis, we can actually activate that CB1 receptor, which then will release that gut-brain hormone and increase food intake. And a lot of times I tell my patients, food just tastes better. Cannabis helps us enjoy things, and this euphorophobia that we've all developed around cannabis, I think when we start to have a conversation about what does it mean to get high, patients start to understand that maybe this medicine will help them enjoy being around their spouse again, their kids again, maybe they won't be so irritable, maybe they'll enjoy conversations and food and other things like that. And pain is definitely one of the top conditions why people are coming to see me. And this, again, is another little snapshot. Most of them are female. And it's spinal stenosis, it's neuropathy, it's arthritis. And they are on these pharmaceuticals, and most of them have been on these pharmaceuticals for years. And it may be that these pharmaceuticals are working for them. Now what I'm seeing is the changes in Medicare, their physicians are reducing the amount of their opioids. And they're saying, I'm sorry, but Medicare guidelines require me to reduce your dose to this much. Well, what else can I do, doctor? I don't know. So it's no wonder people are starting to consider cannabis. They're desperate, they've run out of hope, it's their last resort. And we know that cannabis is not toxic like opioids or other non-narcotic pain medications. It doesn't cause constipation, it can exacerbate it. It can, in some patients who already have gut motility issues, but for the most part, constipation is not a side effect. We know you cannot have a lethal dose of cannabis because we don't have enough of the receptors in our brainstem. And we also have clinical studies that demonstrate using cannabinoids with opioids actually helps patients reduce their opioid intake. It's not competing. There's no competition at these receptors. I hear that a lot. And depending on the type of pain, really determines the type of cannabinoid that I would recommend. In general, I tell people that I find bone pain, severe bone pain responds really well to THC. I find THC to actually be the better analgesic, anti-inflammatory. I also like THCA for neuropathic or inflammatory pain conditions. And I find that CBD can be helpful in arthritis, mild arthritis. But again, everybody's different. But when I started to get a lot of these patients who came to me on these high doses of opioids, I wanted to figure out how could I transition them off the opioids with THC. So I developed an equal analgesic chart for THC. It gives me an opportunity to develop some sort of best practice, some guidelines around how much THC I want them to have. Now, most people that come to me are petrified of THC, so it can be a process. And we know that other components besides the cannabinoids in the plant can also really affect whether it's going to help with anxiety or pain or sleep. And beta-caryophyllene is one of these terpenes. that when we can identify it in our medicine, we can use it specifically for things like pain, neuropathic pain. And I'm a big fan of doing one cannabinoid at a time. We know that cannabis has so much to offer, and people come into my office and they meet with me and they get really excited when they leave and they want results like that. I like to do one cannabinoid at a time and then build on that so I can identify if they're having side effects. I know which cannabinoid it is, and I know at what dose it's happening, and I can make adjustments then. So it's really important that I set expectations with them. And I always make my patients listen to me talk about routes, because they say, I don't want to smoke it. And I said, that's fine, but you have to hear me out. Because maybe after I tell you about it, you might change your mind. Let me just plant that seed. Because inhalation is the best way for them to control their symptoms. It gives them the most control. It's the most predictable. It's the easiest to titrate. And so sometimes when you tell them that and they're control freaks, they like that. They want to be in control. Inhalation works quickly. I'm going to get more in depth into these routes of administration, but this is just something to give you a quick snapshot. And the route of administration determines the absorption and the bioavailability of these cannabinoids. And this is where we can also see some drug interactions that I'm going to discuss. So when we inhale it, it gets right into our capillaries within seconds. It starts to peak within minutes. It only lasts for a couple hours. And then we have oral mucosal administration. And this is an area that I find to be a little bit challenging. A lot of products on the market that are labeled as sublingual. And in my experience, many of these products are oil-based, and so they don't absorb sublingually. And what happens is a patient expects an onset within 15 minutes. They don't feel anything. They repeat their dose. Another 15 minutes goes by. They repeat their dose. They do that 4 times in an hour, and then guess what? They have a bad edible experience. They've called 911. They go to the emergency room. The emergency room doctors think pot's the worst thing in the world, and it's this bad, we sort of a self-fulfilling problem there. And cannabinoids are fat soluble, so again, they're not in their natural state going to absorb in our mucosa. They need to be formulated to be more water soluble. So there are some good sublingual products on the market, but most of them are going to behave like an edible or an ingestible. And cannabis can enter the body through the gut by ingestion. It can also enter through transdermal products. And usually there's a chemical agent in them to enable the cannabinoids to diffuse across all those layers of skin and into our bloodstream. There's some research to demonstrate that CBD can permeate the skin 10 times more effectively than THC delta 8 THC. CBD is a little bit more water soluble than THC. And transdermal agents, I like these products a lot. They're expensive, but they can be a great route of administration for somebody who's very nervous about cannabis. They can place it on their skin. If they don't like the way it makes them feel, they can remove it, and usually those side effects go away pretty quickly. But some of these companies design patches to last about 8 to 12 hours, so they also have a longer lasting effect. And we can also use cannabinoids and cannabis to apply topically. Somebody mentioned we have a lot of CB1 receptors, CB2 receptors on our skin. And we find that topicals are great for inflammation, skin issues, dermatitis, psoriasis, eczema. Can also help with burns, bug bites. And because it typically does not penetrate the skin into the bloodstream, you're not going to see systemic effects, just localized relief. And they typically work in about 10 minutes and can last for a couple hours. So it's a great way to get someone started if they're really, really nervous about side effects. And here we have rectal administration. So I'm not here to say that suppositories do not work. I've had many patients tell me they do work. They're not as well absorbed as I think we would like to believe that they are. And many of my patients will use them and tell me they pass gas, and when they fart, it smells like pot. And then they also tell me they find it in their underwear. It's a very limited population I'm going to recommend this to. But it doesn't go through the liver, so the side effects are usually a lot less and more tolerable, and patients can have a nice sense of whole body relief from them. So if we're concerned about drug interactions, it might be really nice to either use a transdermal or a rectal product. And so what's happening with cannabis when we ingest it, and even when we inhale it, we have these enzymes that are responsible for metabolizing all of these drugs, including cannabis. And these enzymes can either increase or decrease the levels of cannabis. And believe it or not, cannabis can either increase or decrease the levels of some of your pharmaceuticals. And I know you're all going to ask me which ones. I'll get there. So this is one of the CYP450 enzymes, one of the substrates. It's one of the most common ones. I believe about 50% of our medications are metabolized through this one specifically. And when you look at this slide, you might go, well, how am I going to know which one's which? I mean, look, THC can actually increase or decrease. CBD can inhibit the activity of these other medications. So you're going to see higher levels of that drug in the bloodstream. Remember earlier somebody talked about 11-hydroxy-THC, that metabolite? Well, some of these other medications can actually increase that inactive metabolite by 350%. And then, of course, terpenes are also going to play a role in whether or not it's increasing or decreasing other drug levels. But CYP2C9 is one of the more important drug metabolizing enzymes. It can reveal whether a person is a fast, slow, or average intermediate metabolizer. And THC levels can also be affected by other medications metabolized through this enzyme. And then CBD can either increase or decrease the levels of other medications. Large doses of CBD are likely where you're going to see some interactions, and small doses are likely clinically irrelevant. I will tell you that most of the time in my practice, drug interactions are very clinically insignificant, as long as they're being monitored. Then we have the CYP1A2. It actually does not metabolize CBD or THC, but it is important for our ECS activity. And smoking, believe it or not, both tobacco and cannabis can increase activity. So here's some of the drug interactions that I've noted in my practice, and not all of them are a negative interaction. So with opioids, I do see a synergistic effect, and we can naturally reduce their opioids. So patients are often going to start their cannabis regimen while they're still on their pharmaceuticals. Warfarin is one I almost always see an increase in their INR levels. I just had one, I saw a decrease in his INR levels when we changed his product. Just like anything else, though, with warfarin or Coumadin, stay consistent, the levels will plateau, and patients are fine. No, it's not a it's not an absolute no. And the half-life of THC in an infrequent user can be about 1 to 3 days, but a frequent user can be 5 to 13 days. And it can take up to 5 days for us to get rid of about 90% of that dose. So when I'm working with the geriatric population, their ability to process things decreases by about 30%. So I make them wait 3 to 5 days before they even increase their dose. Even if it's not working, I want to make sure that we're going that low and that slow. And I just think it's really important that when we're working with our patients, if they're coming to a cannabis clinician, that we're discussing what to take, how much to take, how often to take it, when they need to increase their dose, how long we expect them to be on their therapy, and when they talking about coming off their other pharmaceuticals, and at what rate. A lot of times I ask the patient to go back to the clinician that prescribed those medications to do the reduction. If that clinician won't, then I will help a patient. But I do want it to be a team approach. But many of you may know with cannabis, we don't exactly get collaboration when we're cannabis clinicians. We get called a lot of names, drug dealers, potheads, you name it. I did build in time for questions if you guys wanted it.
My question is, can you kind of repeat what you were talking about, how the sublingual absorption of CBD oil that is pretty much diffused into oil, why that is inferior to water-soluble CBD?
Why it's inferior?
Like
Well,
sublingually.
I'm not sure I understand your question.
I took what you said as that you're not going to have as much bioavailability with CBD that is dispersed into oil versus CBD that is water soluble.
So I wasn't trying to be cannabinoid specific. What I was trying to say here is that there are products on the market that are tinctures, drops of oil, and they're marketed as sublinguals. And in my experience, in my practice, I do not find them to absorb like a sublingual. They actually have to go, they end up getting through the gut and going through the liver, so patients usually don't feel the effects for about 1 to 2 hours. So I'm not saying there aren't products out there that do work as sublinguals, I'm just saying the majority of them actually work like an ingestible that you've. And then it happens with all of the cannabinoids. Yeah.
So you talked about the fact that you're very specific in isolating your cannabinoids when you're beginning therapies with your patients. At what point in time do you start to introduce other cannabinoids? Obviously, the synergistic effect with various terpenes and cannabinoids is important to really getting the full therapeutic effect. So when do you start to advance that?
Such a great question. You know what nurses' answer is to everything, right? It depends. Typically 2 weeks is to determine how they're doing, and if they're making progress at that point, I usually have them go about another 4 weeks. If they've made absolutely no progress in 2 weeks, I may change formulations or start adding in other cannabinoids. So I have them do about a 2-week trial of building up, titrating up their dose before making any changes. And sometimes I'm even adding in different routes of administration at that point too. You know, it's not often that people will come back and say, okay, I'll try the vape, I'll try the inhalation, I'll do it. Yeah, great question. So if you guys didn't hear that, it was, if I can repeat it, I know what you want me to say, but can I repeat your question? I'm talking more about the metabolism around renal insufficiency.
Well, the general metabolism of the cannabis in the body, is it through the liver?
It's generally through the liver.
The kidneys, like most of the medicines that we give?
So if they're going to swallow it, they take an edible, a tincture, likely it's going to go through the gut and through the liver, and that's where you'll see some interactions. There is some data to say that the inhalation can cause some drug interactions as well, so I've seen that as well. Yeah, liver and kidney disease, we definitely want to reduce the dosages that we're recommending. I did have one woman who was in renal failure who the THC did build up in her system, and she developed the vomiting syndrome. Where we had to stop the THC, and she was able to tolerate CBD okay. So, you know, as long as we can kind of expect to probably see it, just monitor them. Yeah.
What do you consider a large dose of CBD? I'm in Washington, and I see it at 5 milligrams, 12.5 milligrams, and then it to be used as needed.
So you're asking what I consider a large dose of CBD? Yeah, I've seen, that's a good question. So I've seen drug interactions around 50 milligrams a day of CBD. It's typically where I'll see an interaction. I consider that to be 25 to 50, I consider to be a significant dose. And some of our patients are using hundreds of milligrams of THC and CBD.